Right, good morning. So I'm from Polokwane in Limpopo, to give you a bit of northern exposure. And unlike the previous two speakers, the long-term health condition I'm representing is definitely not particularly prevalent. However, as this slide importantly shows, it is arguably the most expensive of the long-term health conditions with which we have to contend. And I put up the slide to give you a bit of a ballpark figure, which is at the bottom about 75,000 American dollars. So if you're a Rand optimist like me, then you could say about 1 million Rand per patient per year in terms of treatment costs. So that's the first important point. The second point is that the 26-year-old gentleman you see here has just broken the world cycling record for the distance covered in 1 hour. He also happens to have severe haemophilia. And it shows that there is a huge opportunity here with enough resources to ensure that the person with haemophilia can actually function at a very high level in terms of physical health. A couple of months after this, actually, sadly, the record was broken again by Sir Bradley Wiggins, who I believe has asthma. So just to give you a few numbers for context from the Limpopo perspective, we have about 5 million people, the live births of 120,000, and we expect to have 500 people with haemophilia. There are about 150 who come to the clinic. For two reasons. We don't recognize mild haemophilia. It's just not emerging from the health service. It's not being recognized by the healthcare practitioners. And we've also clearly historically lost a number of severe haemophilias at a time when there wasn't adequate treatment available in the region. So we expect to diagnose 12 new children per year with haemophilia, of which about 6 are severe, and we seem to be diagnosing about 6 of them each year. Now in South Africa, that would equate to about 50 new severe haemophiliacs a year. And if we look at the age group 0 to 20, that would be about 1,000 young men with severe haemophilia. Right, so I wanted to bring that in just to talk about the costs. So at the top right, we have Alex, and he's a representative of perhaps a group that might get access to R1 million per year of treatment. So if that were to apply across the 1,000 young men in South Africa, that would be 1 billion Rand per year out of a budget of 170 billion odd Rand for health. So that's quite a big chunk for a very small number of people. And I guess most of you are sitting there thinking, well, that's not doable. At the bottom, what we might do with, say, 1,000 Rand a year is very little, because that won't buy any kind of treatment for these patients. And one will then face a situation where a life expectancy would be perhaps to the teenage years, and those that survive would be substantially disabled in terms of their musculoskeletal function. So clearly, in dealing with haemophilia, we need to try and work out where do we stand in South Africa in terms of what is an affordable level of care in our context, and what is our goal? Is our goal to have a good quality of life? Is it to preserve good function, or are we looking for impeccable joint health? Because the costs of each of those is quite different. And clearly, there isn't a linear relationship. I've drawn a straight line connecting the two pictures, but there's no linearity between the money invested and the outcome. And in fact, the outcome is strongly influenced by what you do with the money that gets invested. There are two particular areas which impact on cost and cost effectiveness. And the first is whether one uses prophylaxis or episodic treatment. And I apologize if you're familiar with this, but prophylaxis is the administration of clotting factor to the patient at regular intervals during times when they're not necessarily bleeding. The idea being to maintain the factor level at a point where bleeding is prevented. And episodic treatment is administration of factor at the time that the patient bleeds. And the second is even more tricky, which is that a subgroup of patients in haemophilia A, about 1/5 of them develop inhibitors or antibodies to factor VIII. And they then need to be treated with clotting factor concentrates other than factor 8 or factor 9, and those products cost at least 10 times as much. So now you move from 1 million rand a year hypothetical cost to 10 million rand a year. So that's really extremely expensive treatment. Right, so faced with this, what is the sort of practical approach one should have? I think that one has to have a very keen eye on cost effectiveness. So here is another C. I didn't see the C in the list of C's. And I'd like to propose this C to join the list of C's, cost effectiveness. And in haemophilia, we have at least a handful of well-established cost-effective strategies, which I've listed it there: home therapy, comprehensive care, and a healthy lifestyle. And some which are debatable. I've touched on prophylaxis versus episodic and inhibitor issues, but also the dose and duration of treatment and the use of what we call non-replacement therapies, of which there are a variety. These also need to be looked at in terms of cost effectiveness. I'm not going to discuss those this morning. So I'm going to just talk about home therapy and comprehensive care very briefly. So this shows you a joint. On the left-hand side of the screen, a joint in which there has been some bleeding. So that's an early hemarthrosis. Now, blood in the veins is good stuff. Blood inside joints is really terrible because it provokes an inflammatory response. And the consequence of that inflammatory response is what you see on the right-hand side, that the cartilage is damaged and subsequently, eventually, the bone becomes damaged. The synovium becomes hypertrophied with pannus formation. And ultimately, that becomes a very debilitating injury. So a key in the management of haemophilia is, if possible, prevent bleeding into joints, which would be done through prophylactic treatment together with physiotherapy. Or where that's not possible, which is the current case in South Africa, we don't have many patients where we feel prophylaxis is affordable, then treat early. And the idea of early treatment is limit the amount of blood in the joint, therefore limit the inflammation and limit the damage. So what is early treatment? Early treatment is within 2 hours. So if you think in the context of Limpopo, the likelihood that a person with haemophilia can recognize a bleed and then get to a local district hospital, be triaged and receive care within 2 hours is extremely remote. So clearly that's not going to work. We need another plan. And the plan is that we put all these patients onto a home treatment, early treatment program. The elements of that are, firstly, that there needs to be a training program. And that training program is provided by the local haemophilia nurse in Polokwane, plus a haemophilia nurse from the South African Haemophilia Foundation. And I think it's really important to stress that it's my opinion that without that outside agency coming in alongside the state services, we probably wouldn't see this value-added response. Because I'm really not convinced that managers and administrators have a vision for this broader role of the nurse going into patient education, going into particular training programs. So there's a very good national training program which takes patients through the recognition of the bleed, the storage, the reconstitution and the administration of the clotting factor concentrate, which has to be given intravenously, and what to do with in the case of emergencies and who to contact and so on. And there's ongoing support from them. Now that program requires that the patients buy in, and they usually do quite easily. And where we need support from the local clinic staff, buy-in is needed as well. I'm not involved in that, but my nurses seem to do a fantastic job of getting that buy-in. What I have to do is get buy-in from management. So you can imagine that for a given patient, a month's treatment may be a box of clotting factor concentrate. So they're walking out of the hospital with 40,000 to 50,000 rand in their arms. And on a clinic day, half a dozen or a dozen may do that. So that may be 500,000 rand going out the hospital gate for a small clinic. That requires a lot of trust from the managers, and so far so good. It also requires an accountability from the patient, so they really have to monitor what they do with that expensive medication. They have to have records which they bring, and they need to come to us regularly so that we can audit what they're doing and make sure that most of what happens is sensible. And then there's ongoing support and supervision. My cell phone number appears in all of those records right at the beginning so that people can contact me. So we've been very successful with our patients. They're all on early and home treatment, and usually after the first couple of bleeds, getting confidence, things go very well. There is a subgroup where there's a problem. That's the group with inhibitors, because the medicines for inhibitors are very expensive, and taking a little box home to treat one bleed would cost about 40,000 rand. So I haven't had the courage to try and tackle that and say, let these patients take this home for their management. The other really important cost-effective intervention is to have a comprehensive care center. And we've established this in Polokwane. We don't have a physician. I see everybody up to 60 sometimes. We don't have a hematologist, so it's me in that role. The nurse, absolutely invaluable, manages, administrates, right? But I will stop in a moment. The physiotherapist, let me just say, balance, muscle power, muscle strength and range of movement, absolutely critical. We have a very good lab technician. We miss an orthopedic surgeon, we miss a genetic counselor, but we get by. Now, I'll finish by saying three very visual things. The first is that we have the setup on the right of the slide. We haven't been able to bring in the district hospitals and the regional hospitals particularly yet, and we need that continuum of care. It's an issue. Doctor turnover is very rapid, so we train somebody, they leave after a year. Very disappointing. And we've had a problem getting specialists into our regional hospitals. So there we are, the little green square in the middle, the red circles are the regional hospitals, the smiley red faces are the patients. They're rather far from us, and we do need to do something about bridging that gap. The vision is that we have a nice HCC, a comprehensive care center centrally. We'd like to see a team of doctor, specialist, nurse, physiotherapist at regional. We've now managed to do that at one of the regional hospitals, and then we have a vision for what the district hospital should do in this. The bottom box, fortunately, I think is being taken care of. And so I think, having used an extra 2 minutes, I would thank you very much for your time.